Well, I think this is an interesting discussion to have. I think in Washington, what we tend to have is we have everyone who sort of spends their whole career in a policy silo. So I spend all my life in healthcare policy, talking with healthcare policy people, having the same debates about healthcare policy, and presumably, and not thinking really that much very frequently about immigration. And you guys are all presumably have something somewhat similar and don't think that much about the details of healthcare. And yet, the first thing I think certainly I notice, and everyone in my world sort of notices, is that healthcare is an enormously complicated sector of policy. The rules, the entitlement rules, the regulations that are associated with health insurance are very, very difficult. And these guys have done a really great job in terms of trying to understand it, trying to penetrate really what's going on, and trying to interpret and really approach it from an outsider's perspective. So as someone who spends their whole life trying to work on healthcare policy, I kind of impressed how well you've done really trying to make sense of it all. The thing that I think, just as sort of in a policy world, we sort of have these independent silos in terms of how policy how, as policy analysts, we're able to think about different policy sections. It's true also of candidates and people making public policy. When they develop immigration policy, they don't think that much about healthcare policy. And when you develop healthcare policy, you don't really think that much about immigration policy. And obviously, this is not entirely possible. We have these overlap between the policy areas, and this is a pretty good example of one. The public charge rule, which is sort of long established and obviously has an intuitive support for many voters that care about it, hasn't always been thought of as a healthcare policy issue. But we're in a pretty different world now. 50, 60 years ago, healthcare was not dominating the welfare state the way it is today. Healthcare, health insurance premiums were less than $1,000 not that long ago, only a decade or two ago. That was like a fairly standard amount that people would pay. And now we're talking about tens of thousands of dollars for family coverage. It looms large in terms of family budgets, especially for people who are lower down the income scale. If you're earning around the minimum wage, and then also have a healthcare benefit that's sort of worth potentially $20,000 for family coverage, that healthcare benefit is sort of an enormous feature relative to your compensation, and it's also true with respect to the public sort of spending side of things. If you look at CBO data, even in 2008. Healthcare was 52% of means-tested federal programs. By 2028, it's going to be 71%. So healthcare, if you're talking about a public charge, if you're talking about public entitlements, you're kind of really talking about healthcare just in crude numbers. It's not really possible to talk about this issue without talking about healthcare. 100 years ago, absolutely it was possible to talk about this issue without talking about healthcare. Healthcare was not really that important a thing. But really, these days, when you're talking about burdens on taxpayers, it's really all about healthcare that we're talking about. So the other thing that I think really has changed recently, and then again, this is really from a healthcare perspective, is what happened with the Affordable Care Act. Prior to the Affordable Care Act, we obviously had the Medicare program, which is for elderly and certain qualifying disabled individuals, people who'd paid into the program over large periods of time. We had the Medicaid program, which prior to the Affordable Care Act had really been for various sections of what's called categorically eligible beneficiaries. So low-income disabled, low-income families, different low-income elderly, sort of supplemented Medicare. Really for able-bodied working-age adults, the Medicare program didn't really do that much. In a few states, there were sort of tangentially covered, but for the most part, able-bodied working-age adults weren't in Medicaid. The Affordable Care Act really changed that. The Affordable Care Act ensured that the Medicaid program was expanded to able-bodied working-age adults under earning less than 138% of the federal poverty level, which is probably about $15,000 for an individual, and then for a family, it increases. So depending on the amount of people in a household, it sort of increases. So it could be like 20, 30, 40,000, depending on the household size. This means that you get the coverage if you earn less than that, but you don't get you're not entitled to the coverage if you earn more than that. That straight away creates a whole host of complications that were never really involved in healthcare policy before the Affordable Care Act. It creates work incentive issues. It creates questions of people coming in and claiming access to benefits in a way that really was never really an issue that policymakers had to grapple with to anything like the same extent. Nonetheless, I think it's sort of like a big caveat I would suggest is that the Affordable Care Act, the entitlement expansion of the Affordable Care Act, is only about 10% of healthcare spending. And for some of the reasons that were touched on earlier, the able-bodied working-age adults that earn low incomes tend to be fairly young, which means they tend to be fairly healthy. They're not consuming as many healthcare services as people on Medicare. So that's why it's sort of like this strange phenomenon of public policy that I certainly feel as a healthcare guy is that when you throw out a big number, it sounds really huge in almost every context, and then in a healthcare context, it's like, oh, well, that's actually not that big of a number. Compared to the amount of money that the public purse is spending on like TANF, on welfare benefits, even on food stamps, these are enormous, enormous numbers. But in terms of, like, when you talk about, there was an estimate in the public charge rule of $30 billion per year. That's a big, big number, but it's 3% of healthcare spending. So there's a sense in which, like, what does this mean? In terms of a sort of concern and criticism, is the number actually potentially bigger than that? I think there are some reasons to think it might be. Firstly, there is the issue of employer-sponsored insurance. Now, a big reason why not that much is spent in terms of exchange subsidies is because like 90% of Americans that get health insurance through private insurance get it through their employers, and they're not entitled to exchange subsidies or to Medicaid if the employers are providing it. If the offer rate of employer-sponsored insurance to non-citizens is greater than it is to citizens, you might see a larger proportion claiming ACA subsidies or claiming Medicaid than you just kind of might assume from the general population. Secondarily, there was sort of the issue with Medicaid that was touched on. I think a lot of Medicaid looking relatively cheap relative to other payers is because the cost is a little bit hidden. So like if you're a hospital, if you accept Medicaid, you get a lot of tax advantages on the back end. Yeah. You get a lot of discounts from drug companies on the back end. And so the extent to which the actual dollar figure of Medicaid actually represents your true fiscal cost of enrolling an individual Medicaid, that's a little bit uncertain. Then there is the issue, which I think is like really came out of the debate, which it's hard to imagine that this is a serious proposal, which is to provide universal coverage to anyone who essentially shows up. That's not a policy that any country in the world does, and I think there's no way it would actually happen. And the reason is simply this: like we have a lot of medical therapies in the United States that aren't available around the rest of the world. A lot of cutting-edge drug therapies that cost $100,000, $200,000. Now, there's no way that and this is almost separate from immigration policy. Like, there's no way that we would set up an entitlement that would provide where U.S. taxpayers would pay for drugs that aren't available in European countries for Europeans who have cancer to come over, claim the drug spending, get all the treatment, and then go back. Like, aside from all the questions of how that interrelates with the third world and sort of where we're actually sort of seeing the greater flows of immigration, but it does sort of raise the same questions. So it's, and that sort of raises one more point, which is the interaction between the immigration proposals and the single payer debate, which is these things sound really, really expensive if they interact with the existing public law, with the existing Affordable Care Act. How would they interact with a single payer system where there are no premiums, no out-of-pocket costs, where everything is essentially funded by taxes? that I think was the strangest thing of the debate, was that you can almost to some degree come up with a number, as you guys have done, for how immigration interacts with existing healthcare law. I don't know how you even come up with a number for how it would interact with what's proposed on single payer, with the caveat that some of the candidates don't entirely endorse single payer. So Biden's proposal, you could actually say, has not an actual number attached to it. But the Bernie Sanders kind of end of the spectrum, I just don't think you could even cite a number with that. And the final point that I would make is really, how does sort of thinking again about like the feedback between the policy areas, is that to the extent that we have an expanding healthcare system, to the extent that we have a more universal healthcare system, there's a big demand for labor. Healthcare is an incredibly labor-intensive industry, and there's a lot of essentially low-skilled labor that goes into it, especially if you think about long-term care issues. If you think about like the aging of the baby boom generation, in a few years, people are going to be going into their 80s. They're going to need round-the-clock nursing care. They're going to need home health assistance. In terms of the native workforce, traditionally, that has not been where the workers come from for that. Traditionally, you've had a very large share of immigrant workers that are responsible for providing these home health services. And to the extent that spending on healthcare increases, and you see this in single-payer countries around the world, with physician fees controlled, with wages controlled, with a kind of real tight budgetary controls, it really does tend, quite often, you see this in Germany, you see this in England, it tends to feed back into immigration policy, really just under the pressure of workforce challenges, of really keeping the trains running on time in terms of the healthcare system.